Welcome to this video on the diagnosis and surgical management of coronary artery disease. If you haven't already listened and watched the video on pathology and management, that would make a lot more sense if you viewed that one before you went through this one. The other two videos that would be helpful would be to look at cardiac EKG and then cardiac anatomy and physiology. So in this one, as the name implies, we're going to talk about the three main ways that they diagnose coronary artery disease. And then we're going to talk about two surgical approaches to managing it. So one of the ways, of course, is to do an EKG. And as I mentioned, we've already had an EKG video, so I'm not going to go through that now. But that would be very typical, would be to look at EKG findings. Another way that we could diagnose someone with angina or a myocardial infarction or just general coronary artery disease would be through a blood test. So let's say somebody comes into the emergency department and they're experiencing shortness of breath, and maybe they're having some chest pain, or they're having some jaw symptoms or some upper extremity pain. Of course, they're going to hook them up to an EKG right away if they suspect a cardiac cause. And then the other thing they're going to do is to take blood. And what they're trying to do is detect the enzymes and the proteins that leak out of damaged cardiac cells. So these chemicals leak out into the circulation, and then of course they can be detected. So the three main types of chemicals that leak out are creatine kinase, or CK, and you can see that there in the red, troponin, which is in the purple, and then myoglobin, which is in the blue. And then CKMB is another form of creatine kinase. We don't need to get into those level of details, but this simple graph basically shows you relative levels of those chemicals after a myocardial infarction. So from within the first day, right, within 24 hours, we're certainly going to see a big spike in myoglobin. Remember, that's the protein, or the molecule that carries oxygen within the heart muscle. And then the creatine kinase, the two forms, and troponin, you're going to see shortly after. They're certainly going to be rising, and they'll peak about 24 hours after someone has experienced a myocardial infarction. So they'll be taking serial blood tests to track the changes in these blood levels. What I want to focus on, though, is cardiac stress testing. This is something that could be done certainly before anyone has any symptoms. Definitely recommended for people to get a baseline stress test as they approach middle age, just to determine what their aerobic capacity is and to ensure that they are not experiencing or not exhibiting any signs of coronary artery disease. If you remember in the last video, we talked about the fact that really it can in many ways be a very silent disease, and that there aren't always a lot of very demonstrable symptoms. However, if someone's having some fleeting symptoms that could indicate coronary artery disease, or if they're at very high risk, then it could be a test also that's done to really kind of assess the presence of that disease leading to ischemia. In addition to diagnosing, which is the focus of our talk right now, this could also be done following a diagnosis to kind of assess the follow-up, or the effectiveness of treatment, or the effectiveness of the surgical procedure, and it could be help to guide treatment. So you can see that with the type of stress testing, you can see that anything that creates an aerobic threshold or challenges the body aerobically can be used. So most often you're going to see somebody on a treadmill, though there are bicycle versions of stress tests that are done as well. You can see here this gentleman has EKG leads on his torso, so they're definitely monitoring his EKG. You can see those leads here as well. They're going to be monitoring blood pressure. They are going to be asking the person, how they're feeling. They're going to be getting rate of perceived exertion, monitoring them for excessive sweating, for flushing, for excessive shortness of breath, all those types of things. Some other more complicated things that they might do is to, they might be monitoring them with an echocardiogram. This is a form of ultrasound basically applied to the heart, and it allows them to watch how the blood actually flows through the four chambers of the heart. You can see very clearly the patency of the valves, and so here you go, the valves, and you can also be used to detect how much blood is actually being ejected, particularly by the ventricles during systole. So with the stress test, basically you're starting at a very low level of activity, and then you have very specific levels of increased workload that are quite systematic. So usually about every 2 to 4 minutes, they're going to increase that workload. So they'll start the person at a very light exertion and again monitor all these signs that we just talked about, including rate of perceived exertion, keep them there for a while, and then they're going to bump that up to the next level. And so they're going to keep doing that until either they get to a predetermined maximum for the test, or the person's exhausted, they clearly are very tired out, they're vocalizing that they cannot do anymore. Another thing they might be monitoring is oxygen uptake, and as I'm sure you're aware, that the harder you work, the more oxygen your body should be using. If there's a point where that plateaus, the person can't possibly, they're showing they aren't utilizing any more oxygen, you certainly don't want to keep increasing the workload. That would kill the person. So once oxygen uptake doesn't increase anymore, you would stop the test. I didn't mention they'd be monitoring pulse oximetry. If that's dropping, or either from the baseline, or if it's in the 80 to 85%, which is definitely indicating hypoxia, they would stop the test. Certainly don't want the heart rate to go any greater than 190 beats a minute. So if you're thinking about assessing, your calculations for target heart rate and maximum heart rate, we know normal heart rate shouldn't definitely exceed 85 beats a minute. Certainly it'll go up with exertion, but if you're thinking about a middle-aged person, you don't want that heart rate to go up that close to 200. Using the RPE, rate of perceived exertion, we don't want the person to be exercising in the 15 to 18 range, so we don't want them in the hard to very hard or extremely hard version. I mentioned that they'd be visualizing the EKG. Remember, they can watch not just rate but the rhythm, so they can see if arrhythmias start to develop. They could see presence of ischemia through an alteration in the ST segment, so that would be a very clear indication that they should stop the test. They're certainly going to ask the patient how they're doing. We certainly don't want to see chest pain, but again, they're going to be watching for signs of excessive shortness of breath, pallor, nausea, dizziness, and think about it at times that you've been really, really fatigued or tired. They might even look a little uncoordinated as they're kind of walking on the treadmill, and they may say that they're not able to continue. So those are all reasons to stop the test. I've kind of gone through the testing procedure already, but basically progresses through those stages. So if the testing result is positive, that would indicate there's a point before a normal stop to the test at which the heart is no longer able to meet the demands of the body as it's exercising. So that, again, could indicate the presence of some form of coronary artery disease, certainly ischemia. If the test is negative, that means that's really a good thing. The body is able to supply the heart through the normal levels of exertion with all the oxygen it needs. So that would be actually a good outcome. As far as surgical management, there are two forms of surgical management that I want to discuss with you. One is called a PTCA, percutaneous transluminal coronary angioplasty, and the other one is a coronary artery bypass surgery or bypass graft. And you saw on the slide that I kind of skipped over, there is a video that you can watch of the PTCA, so I'll let you watch that on your own. But the basic procedure is that they thread a catheter up through the femoral artery. So they start in the groin at the femoral artery, thread the catheter up through and into the heart, and then they And so that's what you're seeing here is the catheter being brought up through the coronary artery vessel that's blocked. And then they inflate a balloon. And what that does is it compresses that plaque against the sides of the artery. Now, it used to be that's all they did, is they would go up and do an angioplasty. So they would go in and they'd squish that away. And they found, pretty quickly that those clots came back. So then what they've added now is they have a stent, which is just kind of like a little wire sleeve. And that gets expanded, and it's got some force to push out against the artery, and it's much more effective at maintaining an open lumen within the artery. So this is a PTCA, so percutaneous through the skin, transluminal through the lumen of the artery, coronary angioplasty. So they're kind of restructuring the interior of the coronary artery. Usually a person is in the hospital for maybe a day or so, maybe 2 after this. Coronary artery bypass graft is CABG. Lots of people pronounce that as CABG. A synonymous term that I don't hear as often in this area, but I have heard it when I worked in Milwaukee, for example, is DMR, or direct myocardial revascularization. So either way, it means the same thing. Essentially what they're doing is they are taking a vessel, and they're doing just like what we do with a highway, right? If we have a highway that runs through a town and it makes the traffic run really slowly, well, then they create a highway bypass around that slow area. So here essentially what they do is they take either a donor artery or vein, and they essentially just kind of bypass, create a route around the blocked area so that blood can flow very easily.